actually teach every semester. And but I teach it to paramedic students, and I teach it to students that most of them are going to end up working in Central Texas. And so that often means around here, the trauma centers are pretty close by. We've got Austin, we've got San Antonio, we've got Waco. There's a lot of pretty easily accessible trauma centers. But as I'm thinking about you guys, I wanted to make sure I talk about it from the frame of, you know, the fact that you may have to travel long distances. Abdominal trauma is, I want to kind of frame the whole topic. When I think about abdominal trauma, I think about the belly as being a black box is what I think about. And I think of, you know, it's kind of like it's a mystery in there. And unless you have ultrasound, which very few places do, either have it or have the training for it, unless you have ultrasound, it's kind of really difficult to understand, you know, what's the underlying trauma. We can see the overlying trauma, we can see abrasions, we can see, you know, penetrating wounds, but it's really difficult to get a sense of what's going on in that huge black box. And it's a container that is stretchable, it's distensible, right? So it can easily fill up with fluid and we don't know it, fluid, specifically blood. It can fill up and it's very difficult to know it because unlike, you know, the chest, which is a more fixed structure, and if it fills up with blood, that means it's pushing on something else. The belly's not really like that. It can fill up with blood and it doesn't, there's room there. It can distend and it doesn't end up pushing on anything else in a way that would cause pain. And that's kind of a problem for us doing these assessments on these trauma patients of figuring out, you know, who needs to go to a trauma center, who can go to the smaller hospital, who can I spend some time with on scene, who I need to quickly get off scene with. So I want to talk some about when you respond to a trauma call, right? A big fall, a high-speed motor vehicle collision, penetrating trauma like a stab or a gunshot wound. Where do you even start? How do you approach these patients? And so I kind of do what you've probably done many times. I think about it in terms of quadrants. And so one of the things I do in my class is I'll have students draw up this little kind of grid, right? A little 2x2 grid, and plug in basically what organs do you think of when you think of the right upper quadrant, the left upper quadrant, the right lower quadrant, the left lower quadrant. So if you have paper, do that now. If you don't have paper, what I'd like for you to do, each person that's here on the call, whether you're in a training room or on your phone, if you can get to the chat feature, what I'd like for you to do now is put in what organs that you know of are in the right upper quadrant. And I realize this is super basic, but this is just where I want to start. So in the chat, I want you to write, thanks, Sean, what goes in the right upper quadrant. We've got gallbladder, spectacular. We've got the liver. We've got small intestines, liver, large intestines. What else is up there? So the upper border of the right upper quadrant, when we think of the abdominal cavity, the true peritoneal cavity, the upper border is the diaphragm, right? And so we end up talking about the diaphragm some in abdominal trauma because it can get damaged if we were to be struck in the abdomen and those abdominal contents kind of push on the diaphragm. So it's not really an abdominal, it's not a contents of the abdomen, but it is a border of the abdomen. Thanks, Brandon. Put in pancreas. Absolutely. The pancreas kind of spans both left and right upper quadrants, and it's particularly deep. The pancreas is a very, very deep structure, whereas the liver is very anterior. All right, now you guys did awesome. Now let's move over to the left upper quadrant. What's housed there? Cool, cool. Yeah, you guys are hitting the big ones. The stomach and the spleen, those are kind of the unique ones. The spleen sits really high up in the left upper quadrant, tucked under the ribs. The stomach is more in the true abdominal cavity, it's more anterior and not protected by the ribs. Kidneys, very good. The kidneys are retroperitoneal, but they are in the upper quadrants. Pancreas is also over there. Thank you, guys. Colon. Great. Now let's move down to the right lower quadrant. So now we're in the lower quadrants. We've got the colon, reproductive organs like the ovaries, the appendix, large and small intestines. And the urinary bladder, absolutely. Kind of sits midline, as does the uterus. And then how about the left lower quadrant? More colon. Ureters. And some small intestines and ovary. Yep. Excellent. So, graphical kind of depiction, just as you guys said, we've got the liver, that's the majority of it's in the right upper quadrant. It's a solid organ, it bleeds a lot. Some of it can't span over onto the left side. You got the spleen tucked up under the left side, the stomach, that thing in the middle with the black line to it, that's the pancreas. It's kind of shadowed because it's deep and it's behind all of those structures. You've got the ascending colon, the transverse colon, descending colon, and small intestines. There's more in there though. There's more in the abdomen, right? More that we didn't share. The most important thing in the abdomen wasn't on any of our lists. And the reason it doesn't come up on our list is because we sometimes think of abdomen as equaling GI or gastrointestinal. It's just a little unfortunate kind of mind trick, right? You think abdomen, you think GI. Yes, you guys got it. The blood vessels, the vasculature, right? That's what I want you guys to think of first. When there's trauma to the belly, right? And particularly penetrating trauma, and I'll talk about why. I want you to be thinking about vascular trauma. Okay, because in EMS, our job is to think worst first, right? What's the worst thing this could be? Could this be, internal hemorrhage? Could this be the aorta, the vena cava, the arteries feeding the mesentery lining, right? Think vascular. And I love playing that game because it happens every single time, right? We think of GI organs. So don't forget the vasculature. The way I like to think about it is I think of it in, if there's trauma to the belly, trauma to the abdomen, I kind of think of what might be going on under there in 3 distinct ways. I think about hollow organs. So of the ones you guys listed, the hollow organs are things like the stomach, right? I think about solid organs, organs that are really dense and very blood filled, things like the liver and spleen. And then I think about the vasculature. And if you can chunk them into those categories, you can think about, there's basically 2 main pathophysiologies that happen in the abdomen. One is hollow organs will spill their contents. They're not particularly bleedy, right? Think of a stomach, it's actually not that vascular, right? You think of a spleen, on the other hand, incredibly vascularized. There's blood always being filtered through it. It holds a lot of blood. The organ of the stomach, the actual organ, does have some blood supply, but it isn't filtering blood or doing anything like the liver does to blood, right? So it does have some blood supply, but it's just not, hemorrhage is not the main story when it comes to hollow organs. The main story with hollow organ rupture or damage or perforation is spilling the contents. We're going to talk about what is it that it's spilling, what's inside there, versus on the other side, we think about bleeding. We think about solid organs and the vasculature bleeding. And as we kind of talked about before, you can bleed a lot in your belly. You can bleed your full blood volume into your abdomen, right? There's no kind of point at which the abdomen really tamponades the bleeding. It's kind of impossible to fill it up so much that it pushes on itself and stops bleeding, very unfortunately. So you can truly exsanguinate into the abdominal cavity. While we're on the topic of spilling contents, maybe in the chat, you guys could pop in there, what contents do you think are gonna spill? What comes out of the stomach? What comes out of a gallbladder? What comes out of the small intestines? What comes out of the colon? The answer actually for all of those are different things. Every single thing I said are different things. Yeah, so a lot of you guys are pegging on the bile that comes out of the gallbladder, absolutely. We've got waste and feces. And I want to comment on the things you're writing. So feces, right? By the time we're at the end of the GI tract, you're basically, you get to the rectum, you get to the sigmoid colon, the end of the colon, it's basically all feces. There's not a lot going on there. So what is feces? What is it actually? And feces, believe it or not, is almost 50% bacteria. It's bacteria that's in there. So a lot of it's dead bacteria, but some of it's very much alive bacteria. So you can kind of think about the GI tract from the mouth. Well, I would really start with the duodenum and distal, right? That you start at the duodenum and you keep moving along small intestines, colon. The further you get along the tract, the more bacterial load there is. And it's healthy bacteria, right? It's great for the body as long as it stays inside the GI tract. It's supposed to stay inside there. When it gets in the peritoneal cavity, it's not supposed to live there, and it can colonize there and cause an incredible amount of sepsis. So yes, feces, waste. Lane said hydrochloric acid. Absolutely. You think of the stomach, it's almost all of the digestive kind of enzymes. What's being secreted into the stomach is just pure hydrochloric acid, so it's very acidic. Denny said acids, bile. You guys have got bacteria. And urine we talk about once, if you had some type of urinary bladder spillage, the urine, believe it or not, is sterile. As long as it's just fresh out of the bladder, it's initially sterile. So when it dumps into the abdominal cavity, you don't get that same bacterial load as you do through the GI tract. But it is absolutely a hollow organ. So we're basically dealing with kind of three things when it comes to hollow organs that you can spill: bacteria, digestive enzymes, acids, right? And I will talk more about those. When it spills the contents, you can get from either the hydrochloric acid, right? You can get chemical peritonitis, or all that bacteria, you can get bacterial peritonitis. And so I need to define what peritonitis is. Peritonitis is quite simply irritation of that peritoneal lining. So all in the abdomen, you've got a lining that kind of covers all the organs, holds things in place. And it has nerves that can become irritated, and that inflammation causes pain. And the inflammation can come from chemical or bacterial, right? So itis doesn't mean infection. Itis means irritation of. And you think of like appendicitis, it is irritating because usually it is infected. So that's the case with peritonitis. The peritoneal lining is irritated, sometimes from chemicals, like directly you just spill hydrochloric acid into your abdomen, that's going to hurt. And then sometimes it's bacterial infection, inflammation. And those two processes have a very different presentation in your patient. And the difference is with chemical peritonitis, they instantly have pain. It hurts immediately. With bacterial peritonitis, it can take hours. They don't initially necessarily have pain. And that's troublesome for us because we're doing assessments on patients who've just had their motor vehicle collision, just been shot in the abdomen. And it's very possible for, their colon to be open, spilling that, as you guys said, feces, spilling that bacteria into the abdominal cavity. But until that bacteria kind of starts to colonize and set up shop in the peritoneal lining and in the abdominal cavity, it doesn't actually hurt them, unfortunately. Now, there are other structures that are damaged. They probably have some pain, but the actual bacterial peritonitis is just not going on yet. And their pain will start increasing over time. And that's a problem for us because it's not an initial acute presentation, unfortunately, when you talk about peritonitis. It is if it's chemical, it's not if it's bacterial. So how do you know if somebody has bacteria? What is that pain like? When they do have the pain, right? So if maybe it's chemical peritonitis. When they do have the pain, it's a unique kind. You may have heard of rebound tenderness or guarding. And I want to tell you what both of those things are, because you guys might not have ultrasound, you might not have imaging, you may be really far away from the hospital and you're really curious what's going on in the belly. We can't look, so we have to use some of these physical exam techniques. And there's a physical exam technique called rebound tenderness. And it's very simple. You just push in on the abdomen. And as you push in slowly, and then you let go quickly. And that letting go quickly creates kind of vibrations or a sudden jolt or jarring to the peritoneal lining that hurts. You can also simulate that by kind of tapping on, if they're supine, you tap the bottom of their heels, those vibrations travel up the body into the abdominal cavity, and that vibrating or the jarring feeling, they'll have an increase in pain, and that's called rebound tenderness. That's a pretty specific sign to peritonitis. Another is something called guarding. You may have heard of guarding. There's something called involuntary guarding, which means when you try to palpate their abdomen, their abs just tighten up, right? That's involuntary guarding. They're not trying to mess up your assessment. It's because of the pain, this involuntary response. That is an indication of peritonitis as well. Right? If it's bacteria and stuff's getting infected, they might not have a fever right away, right? We can't count on that, but we can count on a mechanism, some type of mechanism to the belly, and this rebound tenderness. Kind of an overarching theme that I want you to take from this call is if there's been trauma and there's any belly pain at all, that's ominous. That's scary. That's something to immediately not take off the radar, right? Don't discredit it. Don't assume it's something else. Assume it's related to that trauma. So abdominal trauma and abdominal pain, assume it's something really, really terrible, like chemical peritonitis. The other thing that could be going on is hemorrhage, right? And there's a lot to talk about when you talk about hemorrhage. There's tons to talk about. Particularly in our care, right? This is internal bleeding. This is the worst kind of hemorrhage that you can really dream up, because you can't put pressure on it. So what do? What I'd like for you guys to do in the chat is type in some things that you do when somebody has internal bleeding. You've run these calls before. Somebody you suspected has internal bleeding, or you visualize running these calls. You can't put pressure on the abdomen externally, although some people have experimented with that and there have been trials on that. Thanks, Lane. Lane talked about you can give IV fluids, and I'm going to talk about that. You can put a tourniquet around the neck, make sure the brain keeps the blood in there. It's an absolutely terrible idea, Sean. Thanks. Things that you do are things like keep them warm. And the reason it's important to keep them warm is because clotting can't work if they're hypothermic, right? If it's cold and they're cold, if their temperature is less than 95, 96 degrees, they have a lot of difficulty forming clots because clots depend on enzymes to work. So we got to keep them warm. And that's a basic of trauma that I know you guys have heard, a million times, is keep them warm. What else do you do for internal bleeding?
Got to check, but it looks like maybe Ginger might have just removed herself from the Zoom meeting. So I guess we'll see if she comes back. Mark, do you see that as well?
Correct.
Oh, she's right there. We're good. We're back.
I think it was me. I think I fell off. But I'm back now. So the care plan for abdominal trauma, super straightforward, right? There's just because, unfortunately, there's not a lot to do. What do they need? They need definitive care. They need surgery, somewhere with the ability to do surgery, right? To sew back together the aorta, the stomach, the small intestines. So the care plan is thermoregulation. That means keep them warm. How do you keep them warm? Get them out of the wet clothes. You make sure you've heated your ambulance. You guys mentioned IV fluids. The fluids should be warmed ideally up to 102 degrees. And that's not just something that in a kind of out of hospital setting, we're just not that good at doing. But ideally we give warm IV fluids. You can put a pelvic binder if you think the pelvis has been involved. And that is one way that you can kind of shrink up the container just a little bit by that external pressure. You know, we talked about the fact that you can't put pressure on the abdomen itself, but you can put some kind of circumferential pressure around the pelvis with a pelvic binder. The IV fluids with balanced fluid resuscitation, and I'm going to talk some about how much fluid to give. The answer is not too much, right? And I'm going to talk a bit about that. There's a medication called TXA that you can give. If you're doing ALS care, same for the IV fluids, ALS care, and transport to assist a hospital with surgical capabilities. That's it. There's just not a lot that we can do, unfortunately. So, what to do with IV fluids? This is straight from the text from PHTLS, Pre-Hospital Trauma Life Support, that's built from the American College of Surgeons. And this is from their algorithm that talks about how to give fluid. And they recommend giving what's called a balanced fluid resuscitation. And what you're balancing is giving them enough fluids to kind of keep them conscious and perfusing their end organs, but not so much that we might be busting through clots that have formed. So what they say for uncontrolled hemorrhage, and that little one there next to uncontrolled hemorrhage means places where you have uncontrolled hemorrhage. So that's intrathoracic, that's intra-abdominal, that's pelvic, right? Or uncontrolled hemorrhage that might be external, like from a neck or something that you just can't get controlled. You look at how bad their shock is to figure out how much fluid to give. So they tell you if it's class 1 or 2 shock, to give IV fluids at a keep vein open rate. That means basically you're not giving any fluid. You're just giving a little drip here and there. Or if they are in class 3 or 4 shock, then we titrate IV fluids to maintain a systolic blood pressure 80 to 90 and not above that. And titrate just means slowly give small amounts. So systolic 80 to 90, that's pretty low. So the takeaway here is that we're not hoping with the IV fluids to get their blood pressure. You know, if it's a 60-year-old and their blood pressure is normally 130, 140 systolic, it is not our intention to get them to that number. Because at that pressure, we're going to disrupt clots that may be very weakly forming. This class 1, 2, 3, and 4, if you've not heard of that before, I can break it down into something I think you probably have heard of before, and that is compensated versus uncompensated shock. And so class 1 and 2 is compensated. That means their blood pressure is not dropped. They're compensating, usually with tachycardia. Class 3 and 4 is uncompensated shock. That means they were trying, they got tachycardic, they increased their cardiac output, but it's just not enough to maintain a blood pressure, and they've become hypotensive, right? Their blood pressure's dropped below 80 or 90. And so the idea is just to give just enough IV fluids, isotonic crystalloids like normal saline, lactate ringers, to keep the blood pressure 80 to 90. That map that's down there is a different way of talking about blood pressure. It's the mean arterial pressure. And if you've looked at a heart monitor before and you've ever seen the blood pressure, and then there's a number in parentheses below that or around near that, that's the MAP. And it's a measure of the pressure in the arterial system over time. It's a mean, so it's an average of the pressure that calculates in diastolic and systolic. So they talk about titrating a MAP 60 to 65. I want to talk about spinal motion restriction and penetrating trauma. And I think this is a particularly important one for you guys to hear. And I don't want to tell you to do anything that's not, it's different than your protocols, but I do want to tell you about the newest science and the newest recommendations from the American College of Surgeons. So I definitely speak with authority and certainty when I say this, but I'm also aware that the science is kind of newly evolving, and so it's very possible that your protocols might conflict with what I'm about to say. So I want to be very, very careful to tell you that kind of what I'm about to present is newer science, and you should totally follow your local recommendations, the local protocols, and do not tell them that Ginger Locke on this continuing ed told you to do something different in the field today. Although the current recommendations today, that is the current national standard outlined by the American College of Surgeons, says that for penetrating trauma, right? Penetrating trauma to the chest and abdomen should not be spinal motion restricted unless they're neurological deficits. That's it. That's the guideline. Right? So I'll say it again, that patients with penetrating trauma to the chest or abdomen that don't have neurological deficits, right? So when you check their pulse motor sensory, their peripheral sensory, circulation, motor, if they don't have any deficits, they should not be spinal motion restricted. So why is that? Why would we not spinal motion restrict somebody with penetrating trauma to the chest and abdomen? The answer is you're risking spending too much time on scene with them, right? Backboarding takes time. And somebody with penetrating trauma to the chest or abdomen is at risk for vascular injury. They're at risk. And by slowing down, backboarding them, you're delaying kind of the time it takes to get them to the hospital. The additional thing to remember is that there's no evidence that we have, unfortunately, that spinal motion restriction helps anything. And so there's the risk of delaying care and no benefit that we know of. And so when you've done that, what you've done with the kind of the risk benefit ratio is way off, particularly when it comes to penetrating trauma. So again, that may be different than something you've learned even recently, right? You may have heard, it's possible that bullet struck the spine and they have a spinal cord injury. That's absolutely true. And that's why they say if the patient has neurodeficits, sure, you can backboard them. But time is of the essence, particularly when it comes to penetrating trauma. So this is what their little kind of algorithm looks like. They break it into blunt versus penetrating, right? And over in the on the page, the right side of the page, it says penetrating trauma to the head, neck, or torso. Immobilization not indicated, okay? In the text, when you read it, it talks about if they have neurodeficits, you can. But they've really, really pushed very strongly to try to, when you can, quit backboarding penetrating trauma patients to the chest and belly and neck because they need to get to the hospital. They are at risk for internal bleeding. And there's not a lot we can do at a hospital setting for that. A great question that was asked of, do you prefer lactated ringers or normal saline? Because we've got time, I'll kind of go into a little bit about the difference of the two of those. Maybe where you work, they both exist. Normal saline is just very simply sodium and chloride, whereas lactated ringers is sodium and chloride plus other components of the blood, things like potassium, magnesium, lactate ion. And in general, with trauma, it's recommended that lactated ringers is preferred because it more closely mimics blood that's being lost. But really, hear this: neither have been particularly useful for hemorrhagic shock. What people need who've lost blood is blood. They need whole blood. We can give them a little bit of isotonic crystalloids, lactated ringers or normal saline, just to keep their blood pressure high enough so they don't lose consciousness or keep their systolic 80 to 90. But what they need is whole, when they've lost so much blood, right, that they're in hemorrhagic shock, they need blood products. And that's in most cases, that's at the hospital. You are starting to see a little bit of out of hospital blood admin. While I'm on that topic, I mentioned something called TXA, and I want to make sure you guys know what that is when I say that. So TXA is a new to the out of hospital setting medication, but not new to medicine. It's actually a very, very old medication that's been used for a very long time for gynecological bleeds, right? For postpartum hemorrhage and things like that. And because it's been used for so long, we know that it's actually very, very safe. It's a derivative of an amino acid in your body called lysine, and it does something really, really unique, right? So I want to go back to my face so you can see me, but tranexamic acid is the name of it. And what it does is it encourages clots that are forming to stay put. All right, and I want to get real specific with the language that I use because some people think of it as a clot forming medication, and it's not that, right? It's not a miracle like make a clot drug. How it works is when your body makes a clot, let's say you hit your shin, you get a big old goose egg on the front of your shin. As you're forming a clot, the second you start forming it, your body also has a pathway to start breaking it down so that clot doesn't stay there for all of eternity. So it builds it, but then it also slowly starts chipping away at it. TXA stops the slow chipping away. So it will stabilize and stay there. So it just makes clots that are forming a little bit better. That's it. And that's good because we wouldn't want to give a medication to somebody that just instantly clotted them, right? That would wreak havoc in all other places like the brain and the heart, right? We don't want clots everywhere. So it's a pretty mild drug, in fact. But it has been shown to improve outcomes in multinational trials, right? This is incredibly studied medication. And because a lot of you guys are in the rural setting, if you don't have TXA, it may be something that you guys start talking amongst yourselves about. It's pretty inexpensive, it's very safe, and it's time sensitive. So if they get to the hospital 2 hours after this slow bleeding spleen started, it's not as good. They know that it's better if they get it earlier. So the out of hospital setting is kind of the perfect place for tranexamic acid. When you've got an abdominal trauma patient and you're trying to sort through, are they bleeding in the belly? I think that's probably the main question we ask ourselves. Right, peritonitis and things like that, yes, they're terrible, they're painful, it sets them up for infection. But it's kind of a slower moving process, right? Infection, sepsis, right? They've got potentially trauma in the belly, so they're going to the hospital. That will get discovered. It's the hemorrhage, it's the bleeding patient that we know can't tolerate going to the little hospital, right? They need to get somewhere with surgical capabilities. So when do you suspect that your patient's bleeding internally? That's a tough question. If we had ultrasound, we could see it. On an ultrasound, you can see blood, but even that sometimes gets missed if it's a slow bleed. We suspect it basically by looking at two pieces of data. First is the mechanism. It's some mechanism, blunt or penetrating. And the second thing that really clues you in are their vital signs. And so when I say vital signs, I'm talking about something that's your bread and butter. You guys know what shock vital signs look like. We're talking about hemorrhagic shock. And this is something that, EMTs have been schooled on a million times. So shock signs and symptoms, I think it's worth going over them again though, because they can be so subtle. So I'll talk about the vitals, but I also want to talk about the signs and symptoms, because one of the symptoms or signs that you might notice is anxiety. And anxiety is troublesome for us as clinicians, because we know that being in a motor vehicle collision is anxiety producing, right? We know that. And we've seen plenty of patients that have anxiety just because they went through a really stressful event. And what I'd like to challenge you to do is the next time you see anxiety, is rather than assuming that it's psychiatric or psychological, ask yourself, is this maybe physiological? Right? Ask that first, because that's our job, right? To think worst first. What's the worst thing this could be? When I see anxiety, I think, what physiologically could be causing that? And then later, after I've ruled out or done some due diligence to pick through things like hypoxia, hypovolemia, or sepsis, then I start thinking, oh, okay, maybe this is just psychological. So anxiety is one of the earliest signs, and it alone, right, just anxiety alone is probably not enough to make you think, oh, this person's bleeding internally. But when you put together a whole clinical picture, right, so you couple that with a pretty nasty mechanism, they're anxious, and then you add on maybe a little bit of mild tachycardia. Like, heart rate's about 120 and it's not budging. Like, it's sitting there at 110, 115, 120. Why when I'm just sitting here, they're just sitting in this stretcher and I'm talking to them, trying to calm them down, why is their heart rate not coming down? All right. Sustained tachycardia, heart rate's over 100 that just sit there and the patient is just sitting on the stretcher. That's suspicious. That's not just, we should assume that's something physical going on, something physiological going on, not just anxiety kind of response, okay, a psychological response. Assume it's something absolutely terrible, because tachycardia is not normal. All of you guys right now would most likely are not tacking out over 100. Maybe if you've had a lot of caffeine, maybe, right? Or if you have a fever, right? There's a lot of things that can cause tachycardia, but not being being even shot at, right? Once you get in the safety of an ambulance, you're driving away from that. Things are calming down. You're with care. Your police officers are there. Everything's settling down. Those tachycardias should start coming down. So the persistent sustained tachycardia is very suspicious and usually pretty ominous. I'll tell you this, in the ER, they will not let someone go home until they figure out what's causing their tachycardia, right? If they're sitting there at 120, just sitting in the hospital bed, they don't get to go home until they figure out why they're like that, right? They might do a tox screen and find the methamphetamines, or they might give them a fluid bolus and they realize, oh, they were dehydrated and that brought it down. Oh, they have a fever. Oh, they needed some oxygen. They're a little hypoxic. Okay, but please explore tachycardia, particularly in the trauma patient. Assume it's internal bleeding until you're confident that it's not. Another early clue, so we got anxiety and tachycardia. Another early clue that your patient's bleeding internally is a narrow pulse pressure. And you may not know what that means. A pulse pressure is the difference between the systolic and the diastolic blood pressure. So if your blood pressure right now is 120/80, your pulse pressure is 40. That's a normal pulse pressure, a normal distance between the two numbers. And the way to know if a pulse pressure is normal is that it should be a third the systolic blood pressure. So a third of 120 is 40. And so as the systolic and diastolic, when they get close together, that's a narrow pulse pressure, that is indicative of compensated shock, right? We assume that's, especially in a trauma patient, we assume that's compensated shock because that's what epi does to your body. You get the diastolic blood pressure comes up a little bit, and if you've lost some blood, your systolic comes down a little bit and they start to meet each other. So a narrow pulse pressure is one of the earliest signs of compensated shock, right? And the things I'm telling you, these are like the Sherlock Holmes stuff. It's like they don't have the big obvious, belly that's distended full of, bruising and all of this stuff. They don't, this is the medics, the EMTs and medics who are just particularly keen at having a good clinical suspicion, and they start really noticing these patterns. You start seeing these patients over and over and over again. You're like, I've seen tachycardia. I've seen patients at 120, 130, 140, but usually I can get them to bump down if it's anxiety. But this one's just sitting there, right? Or I've seen a narrow pulse pressure, but the next time I took a blood pressure, it started going back to normal, right? It starts trending normal. You start noticing these patterns. Somebody in compensated shock, it stays pretty narrow until it becomes uncompensated shock and they become hypotensive. The late signs, right, like the bruising, the distended abdomen, depending on how big the bleed is, this can take time. Things like you've heard of Cullen's sign and Gray-Turner's. Cullen's is when you get bruising around the belly button. Gray-Turner's is bruising on the back. That takes time because that belly's got to leak all the way from the abdominal cavity under the skin. You've got to start to be able to see it. That's hours later, okay? I mentioned that the mechanism can help you kind of predict this. And there have been studies that looked at mechanisms. And I just want to break it down just in a very simple way. It's this slide right here. So the percentage of people in this particular study who required surgery for two different mechanisms. If it was a stab wound, and this is talking about penetrating trauma. So if it's a stab wound, that could be intentional or unintentional, right? Maybe they fell on rebar or something, right? If it's a stab wound, actually, no, I want to back up. This is specific to assault. So if it's a stab wound, 15% of those ended up needing surgery versus gunshot wounds, 85% ended up needing surgery. And that's because of two reasons, I think, in the study and what you know about kind of penetrating trauma. Stab wounds are low velocity penetrations versus gunshot wounds are medium to high velocity. And so you just, because of velocity, right, energy equals mass times velocity squared. So if you square the velocity, we know that velocity, the speed of penetration is what causes the most damage. Gunshot wounds are obviously faster. Stab wounds, low velocity, can only go so deep, whereas gunshot wounds obviously can go through and through. I'll take us to some pictures. Right, this is a stab wound. So his head's up on the left side of the screen, buttocks on the right. This would kind of land, I would kind of think of this as, this is the right side. So maybe you guys tell me. I'm kind of thinking to myself as I'm looking at it, what organs, let's say this was maybe a 5 to 6 inch little, well, I guess that's not particularly little, but maybe like a little paring knife. What organs are under that? Good. We went for kidneys. I like it. I like kidneys. It would be difficult to get to the aorta from here, the vena cava from here. He's got a good bit of like back muscles that they have to go through. Something to think about is on the anterior abdomen. This is posterior, so we may have even hit rib here. But on the anterior abdomen, again, stab wounds. So this is his belly button. Right side of the screen is his chest hair. All right, so you've got chest to the right. The anterior abdomen doesn't have a way to, so if someone's stabbing, unfortunately their hand can keep smushing in, right? So you can almost kind of, you think of like smushing your belly, right? With your pointed hand, you can smush pretty deep. So it's not just the length of a knife, it's how much did they also kind of keep pushing into the abdomen, right? How much did their abdominal wall, flex? So they were able to get pretty deep. So that same implement, we think of a 6-inch knife here. Now we can get to the aorta, right? And when people talk about stab wounds, they talk about the cone of death. It's kind of a funny name. But basically imagine an ice cream cone with the tip of the ice cream cone being where the wound is. And that knife can go in all directions. Don't assume it just went straight back, right? It could be going down towards the feet, up towards the head. Now do the same in the chat box, kind of what, besides the aorta, what could they have gotten here? Liver for sure, very good. The liver, we talk about it being in the right upper quadrant, but really that thing's taken up even some of the left. The liver is huge and very anterior. Some of it's tucked up under the ribs, but depending on where they are in their respiratory cycle, right, it may dump down. So that's another thing I want you guys to think about is a respiratory cycle. The diaphragm is moving constantly. So don't think of the ribs as the border of the chest and abdomen, right? It's not like that. The diaphragm can kind of drop down, or it can go all the way up to around the 4th or 5th intercostal space. So a stab wound to the chest, like to the ribs, I should say, right? To what we think of as the chest can absolutely get the abdominal contents. I mean, we think of the spleen, it's really high up there. Same for the liver. So other things you guys mentioned, the liver, the diaphragm, and now, right, the diaphragm is the border, right? It's the border between the belly and the chest, and the chest and the abdomen are neighbors. And so when there's trauma to one, always be thinking the other one, and vice versa, right? Because there's only one muscle that separates the two. Alicia said stomach and intestines, absolutely. And now we're talking about hollow organs, right? So we're worried about spilling of contents. Penetrating trauma is pretty straightforward because it's kind of like, okay, where did they get stabbed or shot and what's under there? And we're thinking kind of also creatively. So when you think of someone getting shot, don't kind of fall into the fallacy that I fell into forever. I thought everyone got shot in the position of anatomical man. I forgot that they might be in like a crouching position or be running away, or who knows how they're bent over or kind of up like this. Right. So where the wound is from a gunshot wound, depending on what position the patient was in, who knows which direction it went, because we don't know what position they were in. We always talk about, bullets bouncing around, and that does happen too. But I think more than anything, I think clinicians fall into this trap of thinking that everyone gets shot just like a picture, a 2D picture on a textbook. I did forever until somebody pointed that out. All right, so now we've got what you've undoubtedly heard of, a seatbelt sign. And seatbelt signs have been studied a good bit too. They've tried to correlate it to, you know, how bad it is, basically. And I think it has been correlated with increased kind of damage, right? But I think it also is a variable of what type of clothing they're wearing, right? Whether or not they get you might mistake it for an abrasion. Seatbelt sign, you know, we sometimes just call it that because it kind of helps us know they're wearing a seatbelt. But what they looked at was really the bruising, right? More than the abrasions. And it does correlate with increased kind of damage. So in this picture, what I'd like for you to do in the chat is think about, okay, this person was wearing that seatbelt higher than recommended. Ideally, we want the seatbelt down on the pelvis, not up on the abdomen. What injuries do we worry about for this person? All right, you see this. What underlying injuries are you thinking? And I hope all of you are asking yourself, like, is he bleeding? Because that's what we're always wondering. Good. Yeah, so ruptured organs and the bladder. Those are two perfect answers for me to kind of spring off of. Bruised or bleeding organs. And that's an important point, is that organs themselves can be bruised. You can get little hematomas and things on like the small intestines. The wall of the small intestines can bruise. So let's kind of pick through those. One answer was ruptured organs. So now I'll kind of ask you guys, you're absolutely right. Now be more specific. What specific organs might rupture? Michelle, yeah, the bladder. Yeah, the urinary bladder. The urinary bladder, we worry about rupturing. Particularly, it's tied to pelvic fractures. All right, so when the pelvis is fractured, we definitely worry about the urinary bladder. The small intestines, the large intestines, the bowel. Okay, good. Yeah. And when you think of bowel, small intestines, these are hollow organs. It takes a good bit to squish them and pop them open. But it can totally be done, right? And that's called perforating them. And it can happen from blunt trauma. Absolutely. What this seatbelt sign means is that they stopped suddenly, right? They were traveling fast and in a frontal direction, right? They were moving forward and they came to a sudden deceleration. And sudden decelerations that you see in motor vehicle collisions or big falls carry tremendous risk. And the problem with them is that many of the structures in our body are kind of put in a place and they're held there. They're suspended there by ligaments. The small intestines are not like that, right? They're kind of free floating. You maybe have seen, operations on TV or whatever, where they can just pull out the intestines, or maybe you guys have had, you've seen C-sections where they just move that stuff out of the way. They're not very fixed in there. They can move around. So and this is an important thing for y'all to hear, with blunt trauma, it's actually very, very difficult to squeeze those things till they pop. What happens is these solid organs are traveling along and they tear on their own things that are suspending them in place. So the liver, for example, is being held in place right now, right? It's not movable like the small intestines are. They can't flex and all that. The liver doesn't flex around. And so imagine a car moving forward, the liver's moving forward. The more dense structures that's holding that liver in place, they stay in place, and the liver shears on itself, and it tears these solid organs from blunt trauma. Like coup contra coup with the brain, in the sense that it's sloshing around. Yeah. Stacy asked about coup contra coup with the brain. Absolutely. I mean, that's what's happening, is that the liver, it's suspended in your abdomen, but it's not like perfectly fixed. And so it does have some motility, and that's good and bad. So when we jog, it doesn't hurt, hurt ourselves, but it's bad when there's a really fast, rapid deceleration. And I can't remember if I put a picture in here, but I want to show you. Yeah, I did. So this is a liver that shows this ligament that sits right in the middle of it. And it's a total anatomical problem for how fast humans are traveling now. For cars, it probably was great. But now that we travel really, really fast, what happens is this less dense tissue, right, just gets torn by its own structure, this ligament. This ligament is some of you guys may have heard, it's a remnant of fetal circulation, actually, is where it came from. And other organs are like that as well. The aorta comes to mind. The aorta is fixed in your body in 3 different places. Oh, sorry, thank you. Y'all couldn't see. I'm gonna share my screen better. Aha, yep, that's my bad. Okay, so here's the liver, right? And this is that ligament I was telling you about that sits right in the middle. You can see it's kind of white, it's fibrous, it's dense. This is outside of the body. This is post-mortem, but right, this is really vascular, softer, kind of spongy liver. And then this ligament that think of like the ligaments in your knee, right? It's real tough and strong, and it tears on itself, unfortunately. So the aorta is also fixed like this. So you think of the liver suspended by a ligament. The aorta is suspended or held kind of in 3 places. One of the most troublesome places is called the ligamentum arteriosum, and it's at the aortic arch. And it's another thing that tears on itself during rapid deceleration. What I thought I might do is go through some of these organs and tell you some of the specific signs and symptoms that go with them. But I don't want you to think that means you should be charged with, I don't want you to think that you're supposed to figure out what organ it is, right? So like things like the spleen, for example, it has a unique finding in that damage to the spleen or an injury to the spleen refers to the left shoulder, right? You get referred pain to the left shoulder. That's a pretty unique finding that can make you suspicious of the spleen and that it's bleeding. But I don't want you to get sucked into those kind of specific signs and symptoms, because what we're looking for is the big kind of glaring shock signs: anxiety, tachycardia, narrow pulse pressure, right? Trauma to the belly. Right, so every organ does have its kind of own presentation, but your job is to ask yourself, could they be bleeding, or could an organ have ruptured and be spilling its contents. You know, we didn't talk about the pancreas much, but it causes big problems. We don't talk about it much because it's actually very, very rarely damaged. It's really, really deep. It sits kind of behind the duodenum, but in front of the spine. And so what it takes, where you see a lot of pancreas injuries, or when people have impaled themselves on like motorcycle handlebars or something like that, where there's something kind of like really pinpoint right there, and it squishes the pancreas against the spine. The pancreas is vascular. It's kind of both hollow and solid. It is vascular, but it contains some nasty stuff because the pancreas contains digestive enzymes. And so when it starts leaking, it's leaking digestive enzymes into the abdomen. And it hurts. That would be like chemical peritonitis. It wouldn't be an abdominal trauma lecture if I didn't talk about the gravid uterus, right? Somebody who's pregnant and they have a large, uterus, and the weight of that can cause supine hypotension. That means just laying on their back normally, if they lay on a hard, flat surface like the floor, and they're in their third trimester and they just lay flat on their back, that can cause hypotension alone. So take away any trauma, that alone. And so that kind of feature, right, that big, huge, heavy pregnant uterus pushing on the vena cava, pushing on the great vessels, can confuse our assessments sometimes. And particularly, we think they're hypotensive when all they need to do is we need to not get them off the backboard, right? Or if they have to be on a backboard, tilt the backboard. But ideally, fewer and fewer backboards happening in the world, in the US now that we're kind of changing our approach to that. But get them off their back and tilt it up a little bit, off to the side. Another thing about pregnancy and abdominal trauma is that they have more blood volume than usual. As they get more and more into their pregnancy, they get up, I think it's up to 1.5 times their normal blood volume. So they have a lot of blood. And that can confuse the assessment because they can lose a good bit before they start showing the signs and symptoms. If someone is pregnant, what the CDC says is if there's trauma and they're more than 20 weeks pregnant, they should go to a trauma center. If they're tachycardic, if they're hypotensive, we worry that they're bleeding, right? For sure. But also remember to tilt them off of being perfectly supine. It doesn't take much. I think it's like 15 degrees or something. Just a couple inches up will potentially help them a lot. So I'm thinking we have about 17 minutes left. Sean, do you want me to keep chatting, or we want to do any questions, or how do you want to proceed at this point?
Do you want to go over your 5 post-test questions that you came up with and see if you can get some correct answers out of them?
Cool. Here I go. I'm not sharing my screen because I got the answers on it. All right, here we go. Shall I go for it? Okay, so if we have a hollow organ, right, the stomach, the colon, and those are injured, are we more worried about sepsis and peritonitis or internal bleeding? And Sean, is it okay if I just freeform it, or do I need to be pretty strict to my questions?
No, absolutely not. You can do whatever. You are in charge. Do whatever you want.
All right, I'm having fun over here.
Yeah, do it. Go for it.
Yes, you guys are telling me sepsis and peritonitis. And the difference between sepsis and peritonitis just means there's irritation of the lining, could be from infection, could be chemical. Sepsis, on the other hand, is strictly an infectious process. So peritonitis can lead to sepsis. I should mention that blood in the abdomen does not cause peritonitis, right? Blood is not irritating to the abdominal lining, to the peritoneal lining. It will be after many, many hours, but in the initial blood loss, unfortunately, they don't have pain associated with that. All right, the major cause of concern with a solid abdominal organ injury is it sepsis and peritonitis or internal bleeding? I feel like you got this one. Yeah, internal bleeding. So solid organs being things like the kidneys, the liver, the spleen. All right, I'm going to give you a scenario. This is a 40-year-old who's been assaulted. They're supine, right? So they're laying on their back. They've got multiple rib fractures to the left axillary region. Okay, so that's kind of left armpit from an assailant's bat, right? So they got struck on the side with a bat. The area is reddened and beginning to bruise. He complains of dizziness, pain on inspiration, and it's referring to his left shoulder. What organ do we worry is injured? Spleen. All right, the scene care of a patient who has signs and symptoms of shock from abdominal injuries should include which of the following? All right, so you're on the scene of a patient with signs and symptoms of shock from abdominal injuries. It should include which of the following? A detailed physical exam, initiation of IV fluids, oxygen administration, or identification of the specific organ injury.
Hey, finally, at least you got some arguing on the chat box. I like it.
Well, what I'm getting is feedback about the fact that I talked way too much about IV fluids and not enough about oxygen. And that's my bad. So I love doing, these checks are not checking y'all, these are checks of me. So yes, this patient, if they have signs and symptoms of shock, will get IV and get IV fluids. But what I didn't do a good job of explaining is that we don't spend time on scene giving these IV fluids, because what they need is, remember, blood. They need blood, or they need surgery. So the question asks about scene care, what you would do on scene. And really with these traumas, and this is a huge learning point that I kind of overlooked, with trauma, you guys know, get off scene quickly, right? So what we don't do is stay on scene too long doing things like backboarding we discussed, but also we don't spend time on scene starting IVs. A lot of people can start IVs pretty darn quick, but sometimes it doesn't go as quick as you hoped. And so what can happen is once you get started and you start trying again, and oh, let's do this, and oh, let's do that, oh no, wrong one, where's my sharps container? It can slow things down, right? So IVs for suspected internal bleeding on the way to the hospital, okay, not on scene. So the best choice on that one was oxygen, which I didn't talk a bunch about, but oxygen is indicated when there is hemorrhagic shock. If somebody's being overeager with giving their IV fluids and somebody has bleeding in their abdomen, what may happen? Do they risk diluting essential clotting factors? Do they risk disrupting clot formation? And does it increase their risk of coagulopathy? And the answer is all of those, right? So all of those are kind of fancy ways of saying giving too many IV fluids can mess up the body's attempt to clot. There is one more thing I'm going to comment on because it's something you guys may be still using, and I want to just mention it. There's a maneuver that we used to use for hemorrhagic shock called Trendelenburg. And that's when we would raise the feet the idea was to auto transfuse blood from the legs into the core. The American College of Surgeons, who I referenced earlier with the IV fluids and all that, they don't recommend Trendelenburg anymore. Just keep them flat, supine. The risk of doing that, the Trendelenburg, there are many risks, particularly like Trendelenburg actually is not just legs up. Legs up is shock position. Trendelenburg is taking the whole bed and doing this, technically. That's not good for people with spinal cord injuries or respiratory injuries. And it doesn't help them a lot, honestly. You're not doing what we thought we were doing by auto transfusing blood from the legs to the core. Your body does that by itself with shunting and the epi release. I did get a question. Is it okay to elevate the feet? It is. I don't think you're going to cause further harm, but it's not recommended. The recommendation is supine. Because let's imagine their spleen or their liver is bleeding, and we elevate the feet, and we're doing what we think we are doing, which is auto transfusing blood from here to there. Well, it's just going to promote more bleeding, right? So now Trendelenburg or feet up is still recommended for things like dehydration or if they're in sepsis or they have other causes of hypotension. But for hemorrhagic shock, for bleeding, it's not a current recommendation. It actually hasn't been since 2005. We just are really slow to change. I've got you guys for a couple more minutes, and I got a question about, it says, I've been told only 2 liters of isotonic fluids and then start thinking about blood. Yeah, I would not go more than 2 liters of fluid. But I don't know how far away you guys are sometimes from a hospital. I mean, could be you're giving slow amounts over time. But yeah, for hemorrhagic shock, we want them to have blood. And the adult can, I think, get up to a liter or 2 of fluid. What other questions do you guys still have? So one question was, what if it was a pregnant female's baby's blood in the mother's abdomen? Could that cause peritonitis? I love the question. So everything in the uterus, so everything in the amniotic sac is sterile. But I mean, you guys have heard of meconium, right? So sometimes babies do pass a bowel movement. So if it's really late in pregnancy, that's the one thing I think of as being inside of there that could have bacteria in it. Yeah, but even that, it's just not a lot of bacteria in there. The baby gets exposed to bacteria once they're born. You are asking a question about rejection of, yeah, I don't want to comment on that because I don't feel like I know that well enough. I used to know that about when here's what I know that can happen. The first pregnancy is not a problem, but the mom can develop antibodies. And so the second pregnancy can create a problem. But I see what you're saying about if that blood got into the abdominal cavity. It's a good point. Thoughts on abdominal wound packing? Yeah, I do. Thanks. We do not. So right now, there's for civilian kind of 911 EMS, we don't pack the abdomen. We pack, you guys may know, right? You pack the junctions. So you can do the back of the neck, kind of the armpits, but never the chest or the abdomen. There's tons of experimental stuff on this, though, used in the military setting where they're putting all kinds of stuff in the belly to do that. And there's something else called Raboa, which is where they go in and they put a balloon in the aorta to stop bleeding as well. Those are very advanced techniques to stop abdominal bleeds. And then some of you guys may still carry MAST or PASGs. I'm pretty sure here they're off all of the trucks. We no longer use those, and PHTLS took those out of the text. I think this most recent text, it's not even mentioned because they haven't shown to transfer any benefit. And it's very similar to the idea of raising the legs. It's like just by putting mask pants, like PASGs, they squeeze the legs, and the idea is it's a idea that works for some conditions, but it doesn't help hemorrhagic shock because it squishes the blood more up into the belly where it's just going to bleed some more. So here in Central Texas, they are no longer used at all. Not even on the truck. I feel like with abdominal trauma, a lot of extreme measures, like people just think, oh, what can we do, right? Because we know something's bleeding in there. We've gotten all these kind of creative things that we've done because there's so little we can do, right? It's like you just transport them, oxygen, keep them flat, keep them warm, give them a little bit of IV fluids, keep them comfy. Like there's just not a ton that we can do. And so I feel like EMS as a profession, we've done creative things like with these PASGs and all that because we're just grasping at straws. But the science has not, or the studies have not really proven that they confer any benefit, unfortunately. Same for IV fluids, unfortunately. Very little benefit with penetrating trauma. In fact, it can cause harm. They need blood. Do you have BLS or ILS giving TXA in Texas? I don't think so. I think it is ALS, which is a tragedy. It's a very safe drug.
Hey Ginger, as questions are still flowing in, if you have nothing else, do you want to talk about your podcast and maybe direct people that direction?
Sure. So if you listen to podcasts, you can find me in Apple Podcasts. The name of the podcast is Medic Mindset. It's 2 words in Apple Podcasts, or it's on Spotify. It's on SoundCloud. If you listen to podcasts, you can find it just by searching Medic Mindset. And then there's also, if you're not a podcast listener and you want to hear people talking about EMS, I guess is the best way to explain Medic Mindset. You can also go to the website, which is just medicmindset.com, and just shop around and see if there's any episodes that sound interesting to you. I talk with some medical directors about one thing I've done that I've really enjoyed is we'll pick a chief complaint like chest pain, and I'll talk to a medical director about, how do they want their medics thinking through these calls of, okay, your patient has chest pain. Where do you even start? How do you know if it's cardiac or not cardiac? When do you suspect it's respiratory? And the thinking series, they're about 45 minutes to an hour. And I think I'm up to about 8 or 9 of those. So different chief complaints like shortness of breath, syncope, agitation. There isn't an abdominal pain yet though. So haven't done that one. So yeah, check that out. I've been making them for about 4 years. So there's a pretty large library of them, maybe 40 or so of them, different topics, all the way from like mental health to talking to medics about their very first kind of year and how that went. I talked to a dispatcher, kind of talk about their perspective. Yeah, thanks for letting me mention that, Sean. It's just a hobby. It's not money making for me or anything like that. It's just a fun thing that I do on the side. So I teach all day kind of in the classroom, but this is just kind of my fun creative outlet on the side.
All right, guys, if you want to stay on and have any questions for Ginger, you're more than welcome to stay logged in. I want to mention that the next EMS Live at Night is the 22nd of this month. It is Cameron Murphy is presenting what he's calling Sugar Beatus, which of course is diabetic emergencies. So he's going to be presenting on that. So look forward to that. That's at 6:30 like always. Ginger, remind me, when is your next? You're joining us again. Do you remember what the topic is or what the date is for your next one?
Let me look.
Yeah, I can't remember. I was going to look it up and write it down, and I totally forgot. So Ginger's joining us again. I just can't remember when you...
Okay, yeah, so November 10th, doing the art of auscultation. Ooh, I cannot talk about that for an hour and a half. So we're going to add to that. Ooh, and then January 12th. I'm excited about this one. Thinking about chest pain. That'll be good.
Well, that's right. You're joining for 3. I forgot we roped you in for another one. So
this is fun. I really enjoyed it.
Yeah, write those down, guys, and let other people know. And of course, we'll promote them. But if you guys don't have any more questions for Ginger, make sure you fill out the course survey on SurveyMonkey, which of course I'll share with Ginger as those links are coming in. Make sure you turn in your rosters, and the course completion certificate will be uploaded probably tomorrow. So take a look for that. If you have anything else for us, let us know. We'll stay logged on for about 5 or 10 more minutes. If not, have a wonderful evening. Be safe. We'll talk to you guys soon.
Cool. And everybody be honest on their feedback, because then I can adapt it a little bit for next time. More of what you want. I'm new here.